All right, let's discuss skin integrity and wound care. Okay, the skin is our body's first line of defense for protecting the underlying structures from invasion of organisms. It's our largest organ of the body. A break or disruption in that integrity is potentially dangerous and possibly can be life threatening at times. As a nurse, you will play a major role in maintaining the patient's skin integrity. You're going to be identifying risk factors that may lead to a break in skin integrity. You're going to try to prevent or reduce that risk, and you're also going to be providing wound care when a break occurs. So let's just review the structures of the skin. Okay, that way you can kind of get a general idea when the wound different phases of wound healing, what is going on. So again, like I said, your skin is your largest organ of the body. It's what protects us. The top layer or the epidermis, they have the actual cells that create that protective waterproof layer. The second layer is the dermis, and it's the elastic connective tissue, and it's mostly comprised of collagen. Okay. This is where the nerve, hair follicles, glands, immune cells, and blood vessels are located. The dermis rest on a subcutaneous tissue or on the subcutaneous tissue. Okay, this is the layer that actually anchors the skin layers to your underlying tissues of the body, and it's where your adipose tissue is or your fat tissue. This layer stores fat for energy. It serves as a heat insulator and it also provides cushion. Okay. It also contains blood and lymph vessels, nerves, and fat cells. So on page 1045, table 32.1, there is a table, table 32.1. It goes over the functions of the skin, okay? Of course, like we said, it does protection. You have the body temperature regulation, psychosocial. It's what gives you your, if you have flawless skin, that beautiful skin. Sensation is how we feel things. It also is where our vitamin D is produced. So you need a little bit of sun, not a lot. Immunological, also you got where you absorb through the skin, through we can do medication patches or gels or ointments. And it also is elimination. It's when we sweat. But the table actually goes into a great detail. I just not going to read word from word. So let's look at the factors affecting skin integrity. Again, developmental stages plays a big role, okay? Your kids or your children under the age of 2 have that thinner and weaker skin. Infants need to be handled carefully to prevent injury because their skin and mucous membranes will injure easily, okay? As we age, the maturation of epidermal cells is prolonged, leading to that thin, easily damaged skin. And you can see why your older adults get those skin tears so easily. Circulation and collagen formation are impaired, leading to an increased elasticity and an increase in risk for tissue damage. And this is where we run into pressure injuries or bed sores or whatever, but the technical term is pressure injuries. It used to be called pressure ulcers, but they had to rename it a couple of years ago. State of health, you're looking at their nutrition status. Do they have adequate circulation so they can get rich oxygen supply to those area? Good overall health. All of this is important for healthy skin, okay? Lifestyle. Body, any kind of piercings in the body. I mean, yeah, they're beautiful. I've had some. I've ear pierced, belly button, all that. But it can also lead to area where it have organisms or microbacteria or whatever crawling in there and causing issues. Okay, prolonged exposure to the sun. The tanning beds, getting out there, turning brown, getting darker. I mean, we've all been there. You were probably still there. IV drug use is another one because of the dirty needles or just any kind of puncture in the skin and you're not wiping it down. Illness, A big one that we look at is diabetes. They have a lot of skin issues. Overactive or underactive thyroid can cause issues. A lot of your hormones, if they get out of whack, will cause you to have some skin issues. Diagnostic measures, any procedure that requires that you have to have a needle puncture, a needle biopsy, if you have to go into a CAT scan with dye, you have to get an IV, or if you had to get a colonoscopy or endoscopy, you're going to have that GI clean out where they make you poop like crazy the night before. So it's going to irritate down in the lower region. Therapeutic measures, bed rest. Believe it or not, too much bed rest can cause you to have some skin breakdown. Cast. I mean, how many people have seen people with coat hangers trying to itch in their cast and they're causing issues? But not only that, all of that area is not getting exposed, depending on how long that cast is worn. Radiation therapy, it can cause some serious issues to the skin, especially if you're getting the radiation lights that are beamed into the tumor or what they're trying to shrink. It causes burning. So it's pretty intense. So let's talk about wound and pressure injury. We're going to talk about both. A wound is basically a break or a disruption in the normal integrity of your skin and tissues. Okay. This can range from you just nicked your finger, you got a paper cut, or it can go as bad as that you've had a 3rd-degree burn that covers your entire body. Okay. This is where when I talk to nutrition lecture, how I said that depending on the degree of an injury is depending on how much nutrients that you need, how much your body is working and burning off all of that stuff that you're putting in there. So the bigger the injury, the worse or the more calories they're going to need, okay, because their body is just fighting like crazy to repair. It can be mechanical, which means like a surgical incision, or it could be physical, burns, stabs, gunshots, whatever punctures your skin. Stepping on a rake and you have three prongs in the bottom of your feet. There is a table on page 1048, 32-3. Just look over it. Just be familiar with the terminology because you're going to use a lot of that when you're documenting your wounds, okay? You're not going to use mediocre kindergarten style words to describe your wounds. You're going to have to be familiar with the terminology, okay? Pressure injuries, they firmly, like I said, they were known as pressure ulcers. It's the localized damage to the skin and underlining tissue that usually occurs over your bony prominences, or it can be related to a medical or other device. I have seen skin issues or pressure injuries from Foley's, OG2 or NG tubes, OG tubes, ET tubes when we're intubated and they're on the lip for long periods of time. That's why after a certain period of time, they may opt if they need to stay on longer, they're going to have to put a trach in. They can be chronic or acute. Most injuries or pressure injuries do occur in your older adults. And why is that? They have that thin skin, okay? So let's talk about your different wound classifications. So you have your intentional wounds. Those are ones that are actually planned invasive therapy or treatment. When you have your surgeries, when you have to have IVs, lumbar punctures, needle biopsies, or stuff like that, okay? Those are planned. Those are intentional. Since these are purposeful, or purposely created for those therapeutic purposes, the wound edges are clean and bleeding is usually controlled. Therefore, your risk of infection is small, okay, because these were made in sterile conditions and they usually have a really quick healing time, okay. On the other end of the spectrum, you have your unintentional wounds. These are accidental occurring from unexpected trauma, okay. Such as sitting on a 3-prong rake that you forgot you laid there and you have 3 holes in your buttock. No, I didn't do that. Stuff like that. Or somebody just like the patient that I had this summer who got shot in his buttocks because he was just minding his own business standing on his porch. So those are unexpected trauma wounds. Infection is high with these. Those edges are usually jagged, and bleeding is not always controlled with these. Okay. So therefore, they're probably going to have a longer healing time. Now, open wounds can be both intentional and unintentional. Okay, because again, you're having the skin is open, allowing for your microorganisms to crawl in. So it could be done that we did it on purpose, or we had that unintentional. They will bleed. They're going to have some tissue damage. You're going to have a risk for infection. And there can be some delayed healing with this. And this is usually like you skinned your knee or you cut your hand on a glass or stuff like that. Surgical incisions is your intentional ones. Closed wounds, these usually results from a blow, force, or strain caused by trauma, such as a brick to the face, a tennis ball to your throat, or any, an MVC, you get the seat belt mark on you. The skin's not broken, but there is soft tissue damage with possible internal injury or hemorrhage. Okay. So when we have MVC patients come in and we have what we call the seat belt sign, which means they have across their stomach this purplish area going across and then even over their chest, then we take it seriously because they could have some internal injury there. Ecchymosis is the big medical terminology for bruising, and then your hematomas is when you have that blood that collects up underneath the skin there. And I usually see a lot of this in your older adults and kids. The kids usually either fall and hit their head, or I had one over the summer that walked in front of a baseball bat and he got a big old little goose egg. So you cannot document that patient has a goose egg. Okay, that's just not proper documentation. You have to put a hematoma or a contusion. Okay, either one. Acute wounds usually heal in days to weeks. Okay, these are the ones that usually have those well approximated edges and the risk of infection is low. Whereas your chronic wounds have that delayed healing process and it can take weeks to months to heal. Okay, I see a lot of this in your diabetic patients. Usually these wounds, they don't have that approximated edges, and they also have a really high risk for infection. All right, so depending on the reference, wound healing can be divided in 3 to 4 phases, but we're going to discuss all 4 of them. Okay, so hemostasis. When you think of or hear the word hemo, you should automatically be thinking what? Blood. Okay, so I want you to keep that in mind when you think about this step phase. Immediately after injury, your blood vessels are going to constrict and clotting begins. Now, the constriction only lasts for a short period of time, and then your vessels will actually begin to dilate, open up, to allow plasma and other blood components to leak out, forming exudate. Okay, so exudate is just like the fluid that collects in the wound bed or the wound itself, but it will cause swelling, redness, heat, and pain. Okay, so that's where the pain comes from, and then you see a little bit of the puckering or the redness around the wound, swelling. Following the hemostasis, you're going to have your inflammatory phase. So when you think of inflammation, what comes to mind? Irritation, infection. Well, when that happens, your body is on defense against the injury. So it sends out all these white blood cells to ingest the dirty organisms, bacteria, cellular debris. Okay. Your leukocytes, those are the first to arrive. And then the macrophages come in, which is very important for your wound healing because they also release growth factors. So we need those. All right, so now your body is fighting the attack, which is they were attacked because of the injury. What changes are you going to see in the person when this happens? They're going to have an increase in temperature. They're going to have an increase in their WBCs because remember, those WBCs is where your leukocytes and your macrophages and all that is, okay? So they're going to be sending them out. You're going to see an increase in the blood. And they're going to be feeling pretty crummy, okay? The proliferation phase is in favor of new life, or in this case, new tissue. Okay, so new tissue, or what we call the granulation tissue. This is the good stuff. Okay, we want to see this. It forms the foundation for scar tissue development. The tissue is highly vascular, red, and it can bleed easily. Okay, during this phase, that collagen, which we talked about in the different skin layers, collagen synthesis and accumulation occurs, which rebuilds which layer of that skin that we did talk about. Dermis, good. Depending on the wound size, the shape, and some other factors will determine how long your body is in this phase. Okay. Maturation phase, or maturing or remodeling phase, you're in the home stretch now. This is when you see the wound fading and the scar begins to form, or you'll start seeing that white line. Okay. Factors affecting wound healing, you can have local or systemic. Pressure will disrupt blood supply to the wound area. Remember, we got to have that good oxygen for things to grow. Desiccation is where the cell dehydrates and dies in that dry environment. That's why when we had to do sometimes those wet to dry dressings, so we promote good cell growth. We may have to put like Vaseline gauze, we'll put some Neosporin. There's all kinds of stuff that we can use. And this is why I say check your order before you go do your wound care, because they're going to tell you what they want. Maceration is when you have that softening or breakdown of skin. I think of this as when we sew up a finger and for some reason they decide they need to wash dishes more and more and more. Well, they get it too wet and then the sutures start pulling through. So if you get too much moisture, you're going to have the opposite. So you got to walk that fine line there. Trauma, repeated trauma disrupts the wound healing process. Just when you think that it's getting healed, you trip, fall, hit it, knock it open, knock a suture loose, and you have to start all over again. So it really does not do you any good to reopen the injury. Edema, any kind of swelling will reduce the blood supply. And why is that? Think about it. Swelling is going to start compressing on your vessels, which then shuts off the blood supply. So it's going to cause some delay in your healing. Infection, body starts diverting those leukocytes and those macrophages from your wound healing in order to go off and fight the bacteria that is now elsewhere in your body. Okay, so we want to prevent that infection. We need all of that to go to the wound for healing. Excessive bleeding, this will result in large clots, which will cause it or interfere with your oxygenation to that new tissue. Okay. Necrosis, or that dead tissue, bad stuff, bad. We don't want it. Okay. It can come in two forms. It can come in slough, which is a moist yellow stringy tissue. Ugh. And eschar, which appears black, dry, and leathery. You're going to hear this terminology, so I would know slough and eschar because you're going to have to document that when you get into the world. Biofilm, this occurs when your wound bacteria grows in clumps, and it makes it harder for the body to fight the infection or fight those organisms. Again, we talked about age. We know what that does. Circulation and oxygenation. What disorders do you think can affect this? Okay, because remember, we got to get good blood flow and oxygen. What do you think can interfere with that? Peripheral vascular disease, cardiovascular, hypertension, diabetes. Those are just a few. There's a lot. Nutritional status. I talked about this in nutrition. You have to have some good nutritional status in order for a wound to heal. Knowing the etiology of the wound directly impacts on assessment and treatment on the wound, okay? Dog bites or any kind of animal bite can be treated differently than you stepping on a nail or you cut your hand on glass. All of that is going to be treated and looked at differently. Medication and health status. Corticosteroids delay healing. Chemotherapy, radiation, all of that. Of course, immunosuppression, if your body is already compromised, it's going to have a hard time repairing wounds. And of course, if you don't adhere to your treatment plan or your patient doesn't adhere to your treatment plan, then they're not going to get any better and the healing's going to be delayed. So we can have some wound complications. We can have hemorrhages, which is that uncontrolled bleeding. The Red Cross, or I'm not sure who does it, but it's Stop the Bleed. They have like a campaign where they actually go around training anybody and everybody on how to stop hemorrhages. Okay, you don't have to be medically inclined. They're there, and they do a great job. I've actually attended one. Dehiscence is where you have that partial or total separation of the wound layers. I've seen this when we've had like above or below the knee amputations and they fell out the wheelchair and landed on that stump and it has split open. Evisceration, this is dehiscence, but it's pretty bad. It's where you actually have separation with internal organs. Usually you're going to see this in your abdominal wall area. Okay. Fistulas is any abnormal passage from the internal organ to the outside. You'll see sometimes this in the rectum to the vagina. It's not a pretty thing. Okay. And it's very, very sad because we've had patients suffer from this. Or one can be actually created purposely, like for your dialysis patients, they'll have an AV fistula in their arm where they connect those two vessels so that way they can do their dialysis through there. So it's amazing how far medical science has came. So let's talk about now our staging. Let's talk about pressure injuries and who is at risk for pressure injuries. Okay. So we're going to talk, I think I've got my slides all out of whack. Risk for pressure injury. Again, we're going to talk about that aging skin, chronic illness, like your diabetes. You have that delayed skin healing there too. Immobility, your patients that are unable to move, turn themselves, just sit long periods of time. That I see a lot of pressure or skin pressure injuries occur with these patients. Again, malnutrition, that's a biggie. Fecal and urinary incontinence. If you've got patients that have diarrhea real bad, it'll scald them. Urine, it burns. Altered level of consciousness, that's another one. They may not remember to get up, move around, or if they have incontinence, that's one of the reasons they're incontinent. Of course, your spinal cord and brain injuries, those are confined to wheelchairs if they don't have people to help them. I had a young man that came in and he had stage 4, and we'll talk about stages in a minute, stage 4 pressure injury to both buttocks, on both of his heels, and some other areas. And the poor guy had like duct tape where he was trying to cover them. And it broke my heart because he just didn't have anybody to help him take care of it. Neuromuscular disorders, you have the muscular sclerosis, all of these different, there's so many out there that can cause you to have impaired mobility to move around. Some other factors we look at is you can have the external pressure, and then we can have the friction and shear. External is, again, when you lay on those bony provinces for long periods of time. Friction is when two surfaces rub against each other, such as like an abrasion. I kind of think of it like a carpet burn. We are pulling our patients up in the bed without lifting them, and we're just sliding them up or pulling them up in them sheets. They are rubbing on that sheet, causing that friction. Okay, so we got to be careful when we do this with patients. Shearing, and again, you're going to see these words in your charting. One layer of tissue slides over another, again, from pulling a patient up incorrectly, or a patient who is sliding down in the bed, okay? So as they slide, the skin's going one day and they're going another. So we got to be very mindful how we position our patients. All right, so let's talk about pressure injury staging. This is just something you have to learn. The more you do it, the better you get. So I want you to do this or try to do this. You don't have to do it now, but do it later. When you cross your leg and leave it for about an hour or two, when you uncross it, you should see a red area. Okay. The thing is, though, when you press your finger on that red area, it will blanch or turn white. Okay. This will fade with time. It doesn't mean you have a pressure injury. So I want you to think of that when you come across a patient who's been lying on their back on that pony prominence for about 2 hours. When you roll them over, you're going to see some red areas, okay? But they should fade within 60 to 90 minutes. So when you're doing your assessments, your physical assessment, just don't assume that because they have a red area that they have a stage 1 pressure injury, okay? Come back and check them in an hour. I bet you it's going to be gone. Okay. In order for them to have a stage 1 pressure injury, the red area, when you press your finger in it, will not blanch. It will remain red. Okay. So it won't have that white thing that comes. Okay. Also, there is no broken skin during this stage. The skin break comes at stage 2. Okay. Sometimes it may first begin to look like a blister, or it may have already broken and you can actually see the dermis area. Stage 3 reflects a full thickness skin loss in which you're going to actually see that adipose or fatty tissue. And you're probably going to see that granulation tissue. And what is granulation? What color is it? Red. Red. Great. And we want to see that. That's healthy. Stage 4 is the full thickness skin and tissue loss. I have seen muscles. I have seen tendons, ligaments, cartilage, and bones. Okay. Not fun to see. And I just don't understand how these patients go through this because it's terrible. Okay. Now you can only stage a pressure injury if you can see the wound bed. Okay. This is important. And hence why we have to do wound cleaning. We need to be able to see the wound bed. Okay. If exudate gets in there, that's why we're cleaning it out, to get a good visualization. I just put this on here to see your stage 1. Usually you'll see it, and we'll see a lot of these ulcers, or not ulcers, I got to quit, pressure injuries that occur on the bottom here in the sacral area. This is the red area. If it is a stage 1 pressure ulcer, it will not blanch and it will not go away 60 to 90 minutes after you get them off of that back. Okay. Then stage 2, you can see where you've got the breakdown in the skin itself. And then in stage 3, you have more breakdown, and then you can just see how bad stage 4 is because it's just not pretty. When I talked about unstageable, this is what I meant. The top one there, that blackness, is your eschar. It's leathery. And then the slough is the bottom left here, and that's that stringy yellow. Ugh. Okay. Slough and eschar, you're going to hear that a lot. Deep tissue injury. This is when you have like the bleeding's up under the skin because you have like it's just what it is, a deep tissue injury. Okay. You have like a bleeding or hematoma. It's going to be like a dark red, maroon, or purple. Okay. There won't necessarily be any kind of open skin. It's just a really, really, really bad bruise that they've got, or ecchymosis is the terminology is. Psychological effects of the wound and pressure injury. Of course, there is going to be some pain, and that's why we offer the pain medicine before we start the wound care, just to make sure that we can try to keep them as comfortable as possible. They're going to be very anxious if they happen to look down and they have this huge open from chest to belly button, or they're missing a body part. So they're going to be very anxious. There's going to be fear. What am I going to do? How am I going to get around if I'm missing this or missing that? Or how am I going to be able to take care of myself at home if I don't have? So you have to think of all this, okay? Wounds and pressure injuries don't just affect the skin, but the whole body as itself. How is it going to impact their activities on daily living? Are they going to be the same? Are they going to be able to do everything? They're going to have a change in body image. That right there is going to be a big one. So nursing process, when we're assessing, we got to look. We really got to use our eyes on this, okay? We are going to conduct our history. We're going to do our skin assessment. We're going to do a wound assessment, a pressure injury assessment, and a pain. So you didn't realize when you do a skin, it's this much, but it is. It's a lot. All right. So when we did the wound when I taught y'all how to do the dressing, remember what we talked about wound appearance, okay? So in your book, there is a great guide, 32-1, page 1062. When you're documenting, we need to know the location, where it's located at, the size, depth, tunneling, and that's where it just tunnels down. We have to really drop that Q-tip down there. The approximation of the wound edges. Are they nice and close? Are they jagged? Are they open? The color of the wound and the surrounding area, because we're looking for signs of what? Infection. Drains, tubes, staples, and sutures. Oh my. Okay, we gotta note all of this, every bit of it. Granulation. Granulation is the what? The red good stuff. It's the new growth. It's healing properly. Slough or eschar. And, oh yeah, what's that smell? Smell can tell you a lot, okay? So this is your wound classification, just something easy to remember. If it is red, that's your granulation tissue. You want to protect that, okay? That's what your goal is, to get there. If it has slough, that's that stringy stuff, you have to clean it or cleanse it, okay? So yellow, cleanse, red, protect, and black, which is your eschar, you need to debride, okay? So just try to keep that in mind, and that'll help you with how you can stage your wounds with this. Also, when you're documenting your drainage, you need to taco time. So we need to know the type, the amount, the color consistency, and the odor. Okay. Know your exudate. I warned y'all I have a hard time pronouncing these. So, serous, which is that clear, watery looking stuff. Okay. And you will have this, at least with most of the charting systems, you can click, so you don't have to spell or pronounce them. Sanguinaceous, it looks like blood. It's got that reddish. Okay. Serosanguinaceous is light pink to red tinged because it has the mixture of the two, okay? Purulent, we do not want purulent, okay? Purulent is bad. That means that it probably has an infection that's setting in. It's thick, it stinks, and it varies in colors. It can be any color, to be honest with you. But you'll know from the foul odor what is going on. Pressure injury assessment, again, when we do a lot of our, and we even do this in the ER, I had to do like a skin risk assessment, how mobile they are, what their nutritional status is. Again, you see how nutrition plays a key in a lot of this. Nutrition is going to follow you through all your different disease processes. Are they incontinent? Do they have areas where they're moist? Okay, you have to think of the women with the large breast, where they have a lot of moisture up underneath their breast. Thighs that are large that kind of sit together. We have to keep an eye on that. And then we really have to document the appearance of an existing pressure injury, because if they're admitted with a current injury, we have to make sure we make note of that. Because if we don't, and then somebody comes up later and goes, hey, where did this come from? They're going to assume it was hospital acquired. Therefore, everybody loses their money. Okay, so just be very mindful when you're doing that. Nursing process. Okay, so in class, I want you to be able to give me what's some appropriate nursing diagnosis for patients with wound problems. For your nursing process, what's your outcome identification and planning? I want you to concentrate on patient outcomes that facilitate wound healing, reduce the risk for complications, and they promote psychosocial adaptation, especially for those that are going to lose a limb or a body part, or they're going to have a disfigurement. Okay, you got to think about how that's going to affect them in the long run. So tell me, what are some appropriate outcomes you can think of? All right, so we're going to be implementing different interventions to prevent the infection, promote your wound healing. We want to prevent any further injury or alteration, and promote them some physical, emotional comfort. You want to help these people begin to cope with this. We may have to do some consults. And also, we want to do the pressure injury prevention. And on page 1069, guidelines 32 through 2, they really are very good at informing you what you need to be looking for to help prevent this. Okay, so what are some things you can do as far as nursing interventions that would be good for any of this? All right, wound care and management. You need to make sure that you're promoting tissue repair and regeneration. And what do we need for new tissue to grow? Oxygen, blood, moisture. We need all of that for that to grow. We want it to be happy. It's like a plant. You have to make it happy to grow. Open closed wound care, we have so much. Sometimes they have to leave it open, sometimes they have to leave it closed. Again, that's why it's so important to make sure that you review the chart before you go in and take care of a wound. Okay. You need to choose your appropriate dressing. Your dressings need to be able to provide a moist environment. They need to be able to absorb your exudate, provide thermal insulation. It needs to be a barrier so that more nasties don't crawl into the area. Also, it can also help. These will reduce or eliminate pain. Sometimes air exposure will make it more painful. And then please look for certain bandages that are pain-free removal. If we put in sutures or we put in staples or stuff like that, we have what we call TELFA, which is a non-adherent gauze that we put on, so when we remove it, it doesn't pull on the scabs and stuff that start forming. In your book on page 1073, there is a table that lists all kinds of different dressings and products. The ones you're going to come into contact right now the most is you're going to have your gauze, your 4x4s, your 2x2s. You may see some Curlex, which is just a real thick wrap, spongy wrap. Telfa, which is that non-adherent or non-stick. You may see some Coban where it's a medical wrap that really sticks really well, holds things in place. So don't get too hung up on it, because this is going to be when you actually get into the different areas of nursing, and you'll learn more as you go to the bedside. Okay, we're not going to be saying, okay, this is this wound, which dressing do you need? Don't worry about that right now. Okay. We do have different drainage systems for wounds. We can have correlated rubber or plastic sheets. These actually drain into galls, or they'll drain it. If it's a lot of drainage, they're going to actually put a stoma bag on there, which is the colostomy bag kind of thing. There is an increase in risk of infection with this. A Penrose tube drain, and there's a picture of one in your book. This is a good example. I've seen people with real deep abscesses. They've had to push that down and leave it open so they can drain out. I've seen huge, like if somebody has a dehiscence where they have fell on, like the woman who fell and split her stump open. We had to put a Penrose tube in the wound itself, and then stitch around it and leave both ends out, so that all of that, because she's going to go back through the wound process, the healing process. So therefore, she's going to have the exudate, she's going to have the fluid increase. So we needed to have that drain out so that we can reduce that swelling that she was going to have. Now, your closed drainage systems, they consist of tubes draining into a bottle or a bag. These include also your chest tubes, or they include your abdominal drains. Or when I had my thyroid out, I had a Jackson Pratt in that, which is like a little bulb that you squish. Also, the risk of infection with this, and the reason they do these is, and it's usually surgically that you have these, is where they're put in so it reduces the infection. And Hemovax is another one, where you actually have like a circle cylinder which collapses on itself. So that's pretty interesting too. And again, you may see this when you get in clinical, or you may not see it till you actually get out there in your chosen area of work. There's other techniques. I mean, there's so much out there. Oh, it's just amazing. We have what we call a fibrin sealant. It contains substances that are naturally found in the body. You have your fibrinogen and in your thrombin. I've actually had to apply this to patients that come in and they have those AV fistulas in their arm, you're diabetic, that are just bleeding uncontrollably, and we can't get the bleeding under control. So we replace these on that and hold pressure, and it is amazing. And I'm just really glad that somebody come up with that. Negative pressure wound therapy. These are what you call your wound vacs. And these are applied to the actual wound. And what it does is it promotes healing and wound closure through the application of a uniform negative pressure on the actual wound bed, which reduces bacteria. It also removes excess wound fluid while providing that moist environment for new growth. We also have what we call growth factors. They're naturally occurring proteins. This is usually applied as a gel form on the wound. My favorite, hyperbaric oxygen therapies, where they're put into this hyperbaric pressurized chamber. They actually breathe in like 100% of oxygen, which then increases the amount of oxygen dissolved in plasma, which encourages new wound growth. These people they even have TVs in this for them to sit there. They can usually stay in there for an hour or two. Now, you can't just run out of there. You have to kind of do that whole thing where it has to go back down to the appropriate levels. I almost think of it as your divers, how they have to come up slowly and stuff so they don't have those bends. Heat and cold therapy. Heat accelerates the inflammatory phase, while cold will constrict a peripheral blood vessel, reduces muscle spasms, and promotes comfort. And this is really good to keep in mind if somebody has a muscle sprain or strain. And heat at the beginning is okay, but only like for a day or two, and then you need to switch over to ice, okay? That is a wonderful thing, because what you want to do is you don't want the muscles spasming. So the coldness of it will actually reduce and constrict all that. And I know people think that heat's the go-to, but you want to think about how your athletes, they do a lot of icing injuries, okay? And that's why it's proven to really help with that. If it's really, really bad, they may have to get in there and do some surgery to clean it out. We sometimes have to do OR surgeries where they put the patient to sleep and do a real good flushing of the wound. Of course, we don't want your patient to be awake during that because it isn't fun. So let's just talk about, you will be, as a nurse, removing sutures and staples. We have a suture removal kit. Comes with tweezers, alcohol, scissors. What you do is you just grab that little bow part there and pull up a little bit to get away from the skin. Put your scissors and clip it, and it just pulls right out, okay? If they come back in the recommended amount of time. I've had patients wait a month, and I have no idea how we are able to get these sutures out. They have buried in there so deep. So I always encourage, when I'm educating my patients, to come back in the regular amount of time. It's just very important. Steri strips, excuse me, is that second picture. We use benzoline on the area around the skin. It really gives it that, it keeps those steri strips to close. We've had to do a lot of closures with this. We have some glue called Dermabond, which is really good if it's not in the area that's going to flex a lot. So on your kneecap, your elbow, other areas, if it's superficial and not a really deep laceration, it'll work. So it just depends. And staples, you'll see a lot with head injuries where they'll actually staple it. And we do have a staple remover, and it's a special thing. So don't think that your home staple remover or puller is going to get these staples out, because what it does is when the staple goes into the skin and you go to use that clip, it somehow releases it. It's hard to explain without actually doing it for you. So you are a teacher. Remember, you are a teacher, so you have to teach your patients how to care for their wounds, okay? Supplies, where are they going to get them? About how much they cost. What are some resources to help your patient get these supplies, okay? Wound infection prevention. You have to teach them what the signs and symptoms of an infection is. They don't know. So I always, when I'm discharging my patients, I'm like, all right, this is what you look for. Hand hygiene, when they're changing their bandages, they need to wash their hands, okay? Wear gloves if they got them to do all that. Wound healing, nutrition, protein, and hydrate. Okay, again, there's that nutrition and protein. You never can go wrong. It really aids in the recovery of your new tissue. So when you're evaluating, you want to be evaluating how they are responding to the treatment. If it's not working, we may need to look at this and change some stuff up. Is the treatment effective? Necessary. I mean, when I say the nursing process is ever going, you're going to keep on going. Okay. What is a good evaluation method you could use to see if your patient understands how to care for their wound? Have them demonstrate doing it. Okay. Don't tell them that this is what I'm going to do. Have them show you, because 9 times out of 10, them telling you and actually showing you is 2 different things. Okay. Now stop. Did you document? And you need to use the proper terminology while you're documenting. I cannot stress that enough. Okay. So you need to know the proper terminology. Exudate, purulent drainage, slough, eschar, serous sanguis. Oh, I'm getting there. Sanguis. So you need to know all that. Okay. Stage 1, stage 2, stage 3, stage 4. Okay. And again, always remember, just because you roll your patient over and they got a red bum, that doesn't necessarily mean that they have a darn pressure ulcer. Come back a little bit later and check on them and see if it's still there. Okay. Before we get excited. Skincare, it's not in your book. So we are just making sure that you're aware, being familiar with the skincare or skin cancer. We always have to talk about different types of cancer. Just putting them where it is different. So because it's not in your book, when I created these slides, I really went into a lot of in-depth on the slides. The 3 main types that we're concerned about is your basal cell carcinoma, your melanoma, your squamous cell carcinoma. Okay. The basal cell carcinoma, and I'm not going to read all this because you can read it yourself, and just to make sure we don't run out of time. But usually this is with the repeated sunburns. Okay. It can be hereditary, which is a non-modifiable risk factor. Usually it's slow over months, years. The thing about this one is it doesn't masticize as much. Okay. It's very rare to see that, but it can have that destructive surrounding tissue. So they're going to it depends on the severity of it. They'll probably shave, cauterize. Everything goes for a darn biopsy. Cryotherapy is where they actually freeze it off. That doesn't feel good either. Squamous cell carcinoma, this develops in the epidermis. Therefore, you can get it from IV exposure because you're causing a little damage when you're poking every time. Genetic, again, smoking from the lips, thermal burns, leg ulcers. I mean, just stuff like that. Okay. Again, surgery, might have to have the radiotherapy, which is your another type of radiation and stuff like that. This is just a little visual aid to look at the different types where you have that basal cell. It's like that shiny papular nodule, grows very slow. And then you have the squamous that is more common in your transplant immune compromise. It just looks like a crusting lesion. so you have to keep an eye. Malignant melanoma, malignant is what it is. It is a very interesting. It can be non-cancerous that can lead into cancer. Okay, so that's why you take every mole and every freckle serious. Okay, go to a dermatologist once a year, or have your PCP just do like a skin or just kind of look you over, because it is what it is. We like to get out in the sun. Can't tell you how many times I've had sunburn, sun poisoning, fried to the point where I peeled 3 times. So yeah, and I've had numerous moles removed now too. So common sites, men usually have them on their back, women on the leg, can be in the lips and genital also, and that's not normal. So you got to keep an eye on that. We're going to do surgery, chemotherapy, radiation therapy. Then here's your prognosis. Okay, doesn't look that promising. For this. That's why it's always good. And this is your ABCD. Okay, this is what you want to assess each lesion. So, okay, the symmetry, the borders, the colors, the diameter, and the evolving. Just remember your ABCD. Okay, and that's how you're looking. And this is what your providers are doing when you go in and say, hey, this isn't looking right. Prevention, you can really encourage your patient for prevention. Okay, we don't want to tell them they can't go outside and not be outdoors, because outside you need the sun, you need to do physical activity. But we want them to be take the precautions. Okay, you want to be shaded for the hottest part of the day, and that's usually between that 11 o'clock and 3 o'clock. Cover your skin, sun screen. Water resistant, 4 stars. I always look up every year in Consumer Reports to see which sunscreen is it. Okay. Avoid sunburns, especially in your children. And the fairer the skin, the more protection you want to use. Okay. Again, this is just a little hit miss. Give you some information. Just know the different types, and then how you want to assess them. All right. Well, you'll have a good evening, day.